Lights.
Please. Well, thank you all for coming early this morning and for waking up nice and early. Ra'id, I have your phone, so I'm going to start calling people any second now. We're going to talk about physiology, and it was very challenging to make it exciting for physiology at 9 a.m. on a Saturday morning. But if we can have the lights down, please, we can get started. Lights down, ya shabab. في حدا هنا? No? Lights. Thank you. So we're going to take a walk through physiology. Now, I'm not a superstar in physiology. Just like all of us, we all use physiology in our day-to-day practice. It's nice to understand more from the evidence, link it to cases, and just see if we can modify our practice or maybe update our practice as we go along. This is not an uncommon scenario. So this patient was referred to our institution. Please, for your kind consideration for CompEdge versus PCI for stable angina. So we looked at the angiogram, and he's got this lesion in the distal right coronary artery, possibly distal left main disease, maybe, maybe not, and this lengthy disease in the LAD and the diagonal branch. Now, we know that coronary angiography is not as accurate as we think it is in predicting ischemia, right? So we can underestimate significantly. 31% of lesions between 40 and 50% are significant. 35% of lesions between 50 and 70% are significant. So we can underestimate disease that looks to be moderate. We can also overestimate disease that looks to be severe. So 20% of lesions between 70 and 90% are actually not significant. So for this patient, the FFR in the LAD was 0.82, the FFR in the right was 8.2, the FFR in the LAD was 0.85. Based on evidence, we can defer any intervention for this patient safely because there's no evidence of ischemia on pressure wire assessment, and this is backed by 2-year results and 5-year results and 15-year results from the deferred trial. In these patients, the risk of death or MI is very low, and this risk is not improved by intervention. So what about a case like this, where there's a high likelihood of intervention? We've got this patient with this proximal LAD hazy lesion, this moderate circumflex disease, and what appears to be a severe proximal right coronary artery lesion. If we do an FFR of the right coronary artery, it is very negative at 0.89. The FFR of the circumflex is negative at 0.92, but we have a significant FFR in the LAD. So we choose an FFR-based revasc strategy, and we just treat the LAD. Is this reasonable? Is this a reasonable thing to do when we have multi-vessel disease? And we've got data from FAME to say that it is quite reasonable and very safe to use an FFR-based strategy in this revascularization. We have a reduced MACE rate at 1 year, which remains up to 5 years, and we have similar survival at 5 years from the deferred patients and the interventional patients, which again backs up data from defer that says it is safe and entirely reasonable to defer patients with multi-vessel disease. But what if I have a patient with stable angina and a significant FFR of 0.77? Courage trial, Dr. Fawaz, courage trial, no evidence, no data, medical therapy, why not? You're not improving anything. Why do we not just give him medical therapy versus still give him medical therapy, but also do intervention and revascularize the patient? And the data from FAME2 suggests that patients with significant ischemia who are deferred have a worse outcome compared to those who have intervention. And this is mostly driven by urgent, unplanned coronary revascularization. This was pre-specified. So these are not patients who think, well, doctor, I still have a blockage, I want you to fix it. These are people that come via ER, half of which have abnormal ECGs with dynamic changes. Some of them have actually have biomarker elevation. And these results hold up to 5 years, so similar results, and is therefore entirely reasonable in stable disease, once you have proven ischemia on FFR, to revascularize these patients because they do better than medical therapy alone. But what about the left main stem? So this is a patient with this intermediate, maybe closer to severe distal left main disease, maybe on the caudal view. And there's obviously the circumflex lesion. But if I do an FFR for this patient and the FFR is 0.82, and that's exactly what we found in this particular patient, and I treat him medically, is that a reasonable thing to do? Is it acceptable to do this in left main? This is not a distal LAD mid RCA. This is a left main, large territory, prognostic vessel. What about this patient who's got this borderline intermediate ostial or very proximal left main lesion, and I do an FFR and it's 0.75. And in this particular patient, we do an IVUS, he was stented outside, and whoever stented his left main missed the ostium, so there's a geographical miss at the level of the ostium with a tight MLA, and we refer this patient for bypass surgery. So is the approach reasonable in both these patients? If you have a negative FFR, you defer revascularization, and if you have a positive FFR, you go for revascularization. Well, there is actual evidence that it is still safe to defer patients with a negative FFR. So if you have an FFR of greater than 0.8 or equal to 0.8, then you have similar 5-year MACE rates and similar survival to people who are deferred. So it is reasonable, and that's why it's a class 2A indication in the current ESC guidelines. So what about bifurcations? Can pressure wire assessment help us devise a better strategy or an easier strategy when we do bifurcation? So you see this patient has this eccentric distal left main lesion. He's got this, what appears to be significant proximal circumflex disease and this severe LAD diagonal disease. So in this case, we do a pressure wire assessment of the circumflex and the FFR is 0.97, very negative. And then we end up doing image-guided intervention to the LAD in the diagonal. We stent the LAD and we treat the diagonal with a drug-coated balloon. And we go back and we do an FFR post-PCI to the LAD to reassess the left main once we've treated the LAD. And the FFR is 0.9. So we're happy to stop at this point, and we have a very good angiographic result. We know the circumflex is not significant, and we know the left main, now that we've done the LAD, was not significant. So here's another question for us. Of the operators in this room, hands up if you do not always do a post-PCI FFR. I think all of us, most of us. Abdelhadi does it every time, his hands are down. But we are all guilty, and I'm the first to tell you, and as I look at my cases, we do an FFR, it's positive, you do the PCI, you can do it with image guidance, you're optimized, and you've got a perfect result with IVUS or OCT, and you're very happy and you walk away. But more often than not, our utilization of imaging is not very high in the Middle East, less than 10% imaging throughout our cohort. So should we be doing FFRs post-PCI? Well, we know from data that an FFR of greater than 0.9 is associated with a good outcome post-PCI. But what if you have a low FFR? So if you have an FFR of less than 0.8 or equal to 0.8, there's a greater level of target vessel MI and death. So you have worse outcomes when the FFR is below 0.8. If it's 0.86 or below, you have a greater chance of target vessel failure. And once you reach an FFR of 0.9, going above doesn't really change. So it seems like a target of 0.9 or somewhere around 0.9 is a reasonable thing to aim for, because a low FFR post-PCI is associated with worse outcomes. We'll come to that in a second as well when it comes to iFR. So iFR is a newer modality. It came after FFR, became utilized really quite often from 2014. And this looks at the wave-free period in mid to late diastole. This is where microvascular resistance is naturally low and is stable. So it's a resting index without hyperemia, and it's much faster and easier to do. So here are two LADs, both of which appear to be moderately severe angiographically. We do an iFR and FFR to the one on top, and they're both negative. I do an iFR and FFR to the one on the bottom, and they're both positive. And it seems to be that in most studies, there's about 80% concordance between iFR and FFR. So negative, negative, positive, positive. There's going to be 20% discordance, where one may be positive and one may be negative. So is this associated with a difference in outcomes? It doesn't appear to be the case. So we've got Define Flare and iFR Sweetheart, two very large randomized controlled trials, each with more than 2,000 patients per trial. And it seems to show that there is a non-inferiority when you use iFR compared to FFR at 12 months. And it seems to be the case at 15 months, but you have a shorter procedure time, lower costs, and less patient discomfort, particularly in places like Europe and US where you have a continuous adenosine infusion. We use more intracoronary in our part of the world, but it's a very uncomfortable feeling to have a continuous adenosine infusion. So they should be equal, they should have equal outcomes, but still there's a meta-analysis that raises some concern. So this came out relatively recently, and it showed there's a 2% overall increase in mortality in iFR patients. And we don't know why. There's no patient-level data to explain why that's the case. When they compared the deferred patients on both sides, there was still no difference in mortality. I don't really know what to do with this data, and I don't think we know what to do with it yet, but I think hopefully we'll understand more in the future. So iFR has another nice advantage, which is co-registration. You do fluoroscopy, and you withdraw your wire, and you get a roadmap of where the ischemia is when you treat the patient. So you have an idea of where where the patient is most ischemic. Even though it appeared to me angiographically to be intermediate, it was actually quite tight on IVUS, and we end up being guided by the iFR and we do our intervention. When you have a patient like this who's got a very positive stress test and symptoms of angina, the disease doesn't look very impressive, but you do an iFR, and it is quite significant. The iFR is 0.85, but this is diffuse disease throughout the vessel. This is not focal disease. And in patients like this, we don't really do intervention. They don't benefit much from PCI or bypass surgery. We tend to treat these patients medically only. Virtual stenting is a very nice little bit of technology. So you have an iFR, you have your roadmap of where the ischemia is, and you use your computer and you see, well, what would my predicted iFR be if I were to stent from here to here? It gives you a visualization, it gives you a length for your stent, and you get an idea that, well, if I do this one, I predict the iFR to be 0.96. It's got reasonable accuracy. It's not 100%, but it's not too bad, actually. So in this case, we do it, and we get an iFR of 0.95, despite or 0.94 to 0.95. The predicted was 0.96. That's not too bad. We also see that we've done a post-PCI iFR, and that's very important because you were looking for evidence of residual disease. We do an FFR as well, and they're both relatively acceptable post-PCI for this patient. The only ischemia is some diffuse disease proximally, which we're going to treat medically. So Dr. Fawaz will tell you that these are all very pretty pictures, and it's very nice to look at, but is there any improvement in hard outcomes for these patients now that you have this nice iFR map? And if you take a physiology-driven landing zone for your stents, does that actually improve outcome? Well, this is going to be studied in Define GPS, which has just finished recruiting in May this year, so hopefully we'll get some data for this coming up. So we know that FFR post-PCI is important. Is iFR post-PCI also important? Well, it's very interesting that the data shows that 25% of cases who we think have had a good angiographic result still have ischemia. A quarter of patients still have ischemia after you've done your stenting. 18% are diffuse, and you're not going to do much about it, but 81% are things that you can treat. A third of those, the ischemia is inside your stent, so you need to optimize your stent. A third, it's proximal to your stent, and a third is distal to your stent. So it's always worth doing an iFR beforehand. Is this linked to outcomes? Yes. So an iFR of 0.95 or above gives us a much better outcome than if you've got an iFR of 0.95 of below 0.95. Finally, we'll touch upon tandem lesions, and this is a very, very interesting topic for me. This is a case that I've learned a lot from and I continue to learn from in the future. So here's this patient with a left dominant coronary system. If we look at the anatomy, there is this sort of moderately severe, very proximal LAD lesion. It appears to be eccentric. There's what appears to be severe mid-LAD disease that's very calcific. And there's a dominant circ, which to me, when I first looked at, I thought was probably intermediate and may or may not be ischemic. So we start with our pressure wire assessment. And the iFR, the circumflex, is very significant and it's very focal. As we do our pullback in the LAD, it appears that the sort of proximal to mid-vessel area is where all the ischemia is, but the very, very proximal ostial LAD does not appear to be ischemic right about here. So what do we do with this? How does this change our management? Well, if we go ahead and we do the circumflex, we do our image-guided intervention, we put a stent with a very good result, and we go ahead and we treat the LAD, and we image before we treated the LAD. So So I look at my distal landing zone based on iFR, and there's a very good area to land on. It's an area of 7.8. I look at a proximal landing zone right about where this marker is over here, avoiding the variosteum. There's a good landing zone with an area of 9.6. The LAD ostium has got an MLA of 4.2, and the distal left main has an MLA of 7.6. By most IVUS criteria, not critical, right? So it's not unreasonable to say, based on the previous image, that if we just stent this area that we've treated now, we should have a good outcome for the patient. And that's what we do. So we go and we do our intervention, and this is what we see on the angiogram. And I turn to my staff and I say, guys, this is how you do state-of-the-art PCI. You've done physiology guidance, you've done your imaging guidance, you've got a very good result. I'm now going to prove to you how we're going to have a very good outcome for this patient. Let me show you the iFR post-PCI, and the iFR is 0.87 post-PCI. And you ask yourself, what went wrong? You've done everything you should do. You've got a very good result, and the iFR is ischemic. So you go back and you do your pullback. Now let me show you, this is us pre-PCI, and this is our pullback post-PCI. And this is where the concept of tandem lesions is very important. So we're all aware that a severe proximal lesion will give you a lower distal vessel FFR, right? Or iFR, because you've got ischemia because of the proximal obstruction. But what we must also appreciate is a more distal lesion will also affect the iFR, FFR for your proximal lesion. And once you remove the distal obstruction and the flow is better distally, it highlights how important the proximal vessel was. So the ischemia became more apparent for the proximal lesion now that you've opened it up distally. So we go ahead and we do image-guided provisional left main stenting. We go back to the left main, and we then repeat our iFR, and now it's 0.97. So to summarize, coronary angiography can underestimate or overestimate hemodynamic significance in intermediate lesions. iFR and FFR seem to have similar outcome data, sort of. This meta-analysis throws a wrench in it, and I'm not sure exactly how to understand it. It is safe to defer lesions with negative FFR and iFR, and this includes multi-vessel disease and left main stem disease. And if there's one thing to take from this talk, and if there's one thing that I have learned myself in the last few months in my practice, is post-PCI physiology is very important. We think we've done a very good job angiographically. We might even have done a very good job with intravascular imaging, but there is ischemia that we may miss, and this changes patient outcomes. So it's very important, if we're going to do one thing after today's talk, is when we go back to our cath labs and we do an FFR-guided intervention, we do another FFR or iFR post-PCI and go back and optimize if we need to. And the final thing is to beware of tandem lesions. Your proximal vessel and your distal vessel are not isolated, and they will both affect each other. So I'd like to thank you all for coming, and I'd like to thank your attendance. And I'd also like to give a big thanks to my cath lab team, especially these two, Ghaith and Hanan. And I have to say, whenever I do one of these talks, somebody has to go through hundreds of my cases to find me the ones that I need to get. So I'll tell them, go find me all my FFRs and all my FFRs and find me my tandem lesions. And it takes hours and hours of work. So I'd like to thank them for their effort. Thank you.